Hello, everybody. This is James, and today we're going to talk about gout. Well, did you know that gout was historically known as the king's disease? Why? Well, this was due to the prevalence of gout among royalty and wealthy individuals, as their diets often included lavish feasts and fine wines that contributed to a high uric acid levels. Not wasting much time, let's learn about gout. But kindly hit the subscribe button and let's get started. So plasma uric acid concentrations greater than 6.8 milligram per deciliter is termed as hyperuricemia, in other words, excessive uric acids in the body. And this actually may be attributed to two important factors. Either your body is producing excessive uric acids, predominantly by the liver, or to some extent by the smaller intestines, or your kidneys are refusing to excrete uric acid levels such that the uric acids will stay in the body, and we will term that as under-excretion. So these two factors can lead to hyperuricemia. And it's important to understand that when uric acid levels exceed 6.8 milligram per deciliter, this actually easily saturates, and this increases the likelihood of uric acid getting deposited in the joints, the soft tissues, and the kidneys. So, in patients who already have a pre existing gout, this may also increase the risk for gout flare ups. So, eventually, this triggers an inflammatory response, which often results in this excruciatingly painful condition we term gout. Well, over time, the accumulation of uric acids leads to chronic arthritis, formation of tophi, renal stones, or even causing damage to the kidneys. It's important then to say that maintaining an optimal uric acid level is crucial in the prophylaxis of this disorder. But interestingly, not all individuals with elevated uric acid levels develop gout. Now let's take a better look at the inflammatory response that occurs in gout. So we have innate cells such as monocyte and macrophages. Now let's take a look at the monocyte. On the surface of monocytes, we see toll-like receptors 2 and 4. And when these receptors comes into contact with the uric acid crystals, what happens is that there are signaling cascades initiated that actually leads to the activation of transcription factors, for example, nuclear factor kappa B. And this would result in the upregulation of pro-inflammatory genes. In other words, there is excessive formation of interleukin 1 beta, which is a very important driver in the pathogenesis of gout. So interleukin 1b is a pro-inflammatory thing which is still not active. Now in parallel, what we also see is phagocytosis. Now the phagocytosis we see by the monocytes would also lead to assembly of multiple proteins which we will call inflammasome. You can think of them as sensors. Inflammasomes will then activate a protease enzyme called caspase 1. When caspase is activated, it is able to cleave or break down the pro-inflammatory interleukin 1 beta into the active interleukin 1 beta, which is then secreted rapidly out of the monocytes. When this leaves the monocyte, it is also able to bind to interleukin 1 receptors on macrophages. It can also stimulate the same receptors in endothelial cells. When this happens, it actually leads to production of signals. Don't forget also that macrophages itself can also ingest monosodium urate. So this leads to signals that further produces pro-inflammatory cytokines, chemokines, including TNF alpha, interleukin 6, and even neutrophils as well. This then leads to the inflammatory form of arthritis that occurs in gout. In addition, monosodium urate crystals can in fact bind to lipids, proteins, or even immunoglobulin G, and this may activate complement and promote opsonization. So here we can recall how uric acids are formed, and we have precursors such as nucleic acids. Nucleic acids are converted into purine. And if you recall, the enzyme that does that is called xanthine oxidase. Purines are subsequently converted into hypoxanthine with the same enzyme called xanthine oxidase. Well, this is important because if we target this enzyme pharmacologically, that is, if we inhibit this enzyme, then we would prevent the formation of uric acids from nucleic acids. And medications that does that are allopurinol and febuxostat. Febuxostat is actually a selective inhibitor of xanthine oxidase. So once uric acids are formed, you recall that levels greater than 6.8 can lead to saturation and the deposition of these crystals in soft tissues, in the joints, and cause problems even in the kidneys. So one thing the body can do is to convert uric acids into a water soluble substance we call allantoin. And the enzyme that does that is called uricase. So, again, pharmacologically, we can use a medication such as rasburicase to enhance the effect of uricase so that uric acids can be converted into a much more water soluble substance such as allantoin. On the other side, we also said that some patients that suffer from gout are under excretors. In other words, their kidneys are not really excreting the uric acid such that the uric acid levels will become high in their body. So, one way that we can get rid of the uric acids is by using some medications we call uricosuric drugs, such as probenecid. So, probenecid is a drug that would enhance, that is, it would kind of reduce the reabsorption of uric acid or promote the effective excretion of uric acid. Again, genetically, certain people may also lack an enzyme such as uricase, and such patients may be predisposed to gout. Again, you can also see that there are inhibitory nucleotides right here. And what they do is that they also help and prevent excessive formation of uric acids. Excessive ATP depletion, or what happens in alcohol intoxication, can actually lead to low concentrations of these inhibitory nucleotides, and this can then lead to excessive uric acid formation. So this disorder can manifest as an acute gout flare, chronic gouty arthropathy, tophaceous gout, or nephrolithiasis. In other words, renal stones, and specifically uric acid stones, as well as nephropathy. Now, regarding the clinical manifestation of acute gout, this usually presents as an asymmetric mono or oligoarthritis. Mono means one joint affected, oligoarthritis, 2 to 4 joints affected. Gout often presents as a sudden nocturnal attacks with or without precipitating factors. The first metatarsophalangeal joint is often affected, and this is termed podagra. However, other joints such as the ankle, the knee, DIPs and PIPs may also be involved. The hips and the shoulders are rarely affected. The symptoms of gout generally include an excruciating pain, swelling, redness, and intense heat in the affected joint, and this may last several days to weeks. Flare up can also be so debilitating, making it even challenging to perform everyday activities. Local desquamation and pruritus may also be noticed, however, this is not always present. Fever may also be present during the acute phase of the disease. Now, uric acid deposition may become hardened in the chronic phase of the disease. This can involve the soft tissues, synovial tissues, or bones near the joint, and are also considered pathognomonic for gout. Tophi may be seen at their external ears, hands, feet, olecranon, prepatellar bursa, and this indicates chronicity. Investigations. Polarized light microscopy will show a needle-shaped, negatively bifringent urate crystals. What is this supposed to mean? Well, under a polarizing light microscopy, monosodium urates may align parallel or across to the axis of the red compensator. The important thing to note here is the compensator, and it has an axis. In this case, this is going to be the red arrow right there. This is the axis of the red compensator. And so if you put uric acid crystals and the crystals align in parallel, or in other words, in the same direction as the red compensator, then the color of the uric acid crystals will turn yellow. And if the uric acid crystals are lined across, that is the axis of the red compensator, the color will turn blue. And this is what we call a negative birefringence. Remember that in pseudo gout, there is a positive birefringence, and this rather looks or has a rhomboid shape. Synovial fluid aspirate is usually clear to cloudy. If it has any white blood cells, this usually ranges between 3,000 to 50,000 microliter. You would also like to check uric acid levels, have a full blood count. You would also like to have urea and electrolytes, C-reactive protein, ESR. Glucose is also very important since hyperuricemia is very commonly seen in patients with metabolic syndrome. Bili as well as creatinine would also be important. Radiography. An X-ray may show no changes to swelling of soft tissues in the early phase of the disease. During the chronic phase, there may be punched out erosions called rat bite, and when this is adjacent to soft tissue tophi, it is diagnostic of gout. So in the management, you will treat acute gout first, then after that, you will treat hyperuricemia. There are some exclusions, so your exam might like to trick you by saying that a patient presents to your consultant and the patient has acute gout. This patient is not taking allopurinol. Would you actually initiate allopurinol? Of course not. So you would treat acute gout first, and then you would treat hyperuricemia after that. However, the exclusion is if the patient is already on allopurinol when they come with the acute gout, then you will leave them on the allopurinol whilst you treat the acute gout. Management of acute gouty arthritis. Encourage bed rest and advise against precipitating factors such as red meat, shellfish, alcohol, or low dose aspirin. Non-steroidal anti-inflammatories such as indomethacin and ibuprofen may also prove very effective. Cyclooxygenase 2 inhibitors such as celecoxib or toricoxib may also be necessary. Colchicine. This seems to inhibit neutrophil adhesion, motility, and chemotaxis. Some side effects are gastrointestinal symptoms such as cramps, diarrhea, or even vomiting. It is contraindicated in inflammatory bowel disease or in the post-surgical period. Corticosteroids. In patients that are unable to tolerate NSAIDs and colchicine, and especially if gout occurs in a single joint, then a local glucocorticoid injection may prove effective. IV glucocorticoids have also been used in oligoarthritis in patients intolerant to NSAIDs or colchicine. Certainly, adverse effects from systemic glucocorticoids may occur in this setting. Aspiration of synovial fluids may be very necessary before initiating corticosteroids. Well, why? Remember, septic arthritis may coexist with gouty arthritis. Management of hyperuricemia. Uric acid levels are very useful in this setting to monitor the effect of treatment. Lifestyle modification is indispensable when it comes to the management of hyperuricemia. Xanthine oxidase inhibitor, such as febuxostat or allopurinol, is a cornerstone for treatment, and uricosuric drugs inhibit tubular reabsorption of filtered urates and promotes renal excretion of uric acids. An example is probenecid, and pegloticase is a drug that dissolves urates and may be used if other measures fail. They may be indicated in tophaceous gout with persistent or destructive arthropathy. Prophylaxis. So patients who have more than one attack per year, existence of a tophi or uric acid renal stones are advised to make modifications to their lifestyle and are also recommended one of the following drugs, febuxostat or allopurinol. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.